Hi, good afternoon. My name is Mohammed Al-Hadi Mohammed Al-Qasim. I'm a medical educator, disaster medicine specialist, and emergency medicine specialist. And it will be my pleasure to speak to you about triage and safe transport for pediatric trauma. And my objective for this lecture is to define what's triage, what's unique about pediatric triage, and then what are the different types of triage and how can we use the accept mnemonic for a safe transfer. So triage as a terminology is actually has been derived from a French word trier, which is mean to sort out, and it has been invented by a French surgeon Baron Dominique Genlery, and he was actually a part of Napoleon army, and he used to have his own approach to categorize soldiers who are less fatal wounds so they can be sent back to fight. And from that time, triage has been evolving, and there are different triage methodology. They vary from country to institute, but they all share common concept that they look at serious presentation, they pay attention to vital signs, and based on that they categorize the patient according to the severity. And the triage can happen uh, at three different phases. So there is a triage as a scene. So if we have an incident, especially if we have many casualty, there's a triage as a scene. Sometimes we might need a special triage to transfer the patient to the hospital, especially for example if we in a place that there is only one hospital can deal with head injury or a special burn center. So we have specific criteria to send. When do we send those patients to burn center, or when do we send them to a normal hospital? So, and also once those patients are has been received by the hospital itself have an emergency department triage. And the triage is just an objective tool to help us as a healthcare provider to decide about the level of acuity. How sick is this patient? So we can decide which patient should be treated first. And also, if the patient is very sick or severely injured beyond our capacity to take care of that, then that also it will help us not to waste our resources for injuries that we cannot save or we cannot salvage. So that's really the purpose of triage. And there are many triage systems and methods. So there are specific triage that are designed for disasters and major incident. So in the USA, they use the SALT mass casualty algorithm. In the UK, recently they published the NHS pre-hospital major incident tool, and there is a jump start, the triage sieve, the triage sword. All these are different triage methodology that are used in disaster situation. And in the emergency department, they have different triage system, and each country they have their own triage. So in the UK and Ireland, they use the Manchester triage system. In the US, they have the emergency severity index, and the Canadian use the Canadian triage and acuity scale, and the Australian has their own, and Germany has their own. So each country has their own triage methodology. In this lecture, I will be mainly discussing two assessments. They're not actually triage. We can consider them as triage, but they are mostly like an assessment that we do for pediatric trauma. The first one is the pediatric assessment triangle, and the second one is the primary assessment. So the pediatric assessment triangle has been adopted by the American Academy of Pediatric, and basically it's without even examining the patient. By looking at the patient, we comment on three main aspects. We comment on the appearance, their tone, their interactiveness, their consolability, how do they look to us, their speech, their cry. We look at work of breathing, and we look at the circulation to the skin. So basically, when we say the pediatric assessment triangle, you do it without even touching the patient, by just looking at the patient and try to observe these three different parameters. And obviously, if you have significant disturbance in more than one of these angles, it indicates that this patient is sick, and you will follow that with a primary assessment, so you can identify exactly what's the problem and you fix that problem. And then the primary survey. So basically, the primary survey in trauma, we do it for any trauma patient, so we can identify life-threatening events. So start with airway, with cervical spine control. So we have to ensure that the airway is patent and maintainable, and cervical spine has been immobilized and maintained. We assess breathing to ensure that the breathing is adequate and there is no life-threatening thoracic injury. And we assess circulation to ensure that we have optimum circulation and the hemorrhage has been controlled and the shock has been treated. And we assess disability to assess for any severe neurological injury, and we expose to look for any obvious trauma or injury or bleeding. And sometimes people add catastrophic hemorrhage before ABCs, because obviously if you have catastrophic hemorrhage, it can kill the patient before even you do the ABCs. Some people say CABC, but the concept is the same. So just remember, and if you have a team member, you don't need to go you don't need to do them sequentially. You can do them simultaneously. So somebody take care of the airway, somebody take care of breathing, circulation, disability, and so on. So we discussed triage. Now we would like to talk about how do we transfer patient. So let's assume that you have a major head injury patient. He's 10-year-old. He has severe head injury. He's unconscious. You intubated him, and you realize that he has some sort of intracerebral hemorrhage, and he needs to be sent to a hospital with neurosurgical facilities. So this patient needs to be transferred from your hospital to a different hospital. So how can you do that? So to facilitate transfer, we use a mnemonic. We call it accept approach. So we assess the patient, we control the environment, we communicate with the receiving facility, we evaluate, prepare, pack, pre-departure check, and we transport the patient. And I will walk you through all these steps in a sequence. So in assessment, we assess the patient problem, the situation. So what's happening? We have a 10-year-old child with severe traumatic brain injury. He is unconscious, he is intubated and mechanically ventilated. The background, does he have any medical problem, or he is a healthy child? Our assessment, now the child is intubated, is mechanically ventilated, his blood pressure is 110/70, his pulse rate is 110, his blood pressure is so and so and so. And the recommendation, so based on the CT scan report that we discuss with the other hospital, that this patient has intracerebral hemorrhage and need to be transferred there to be seen by a neurosurgeon. They are planning to put intracerebral monitoring devices. They are trying to reduce and they are trying to admit the patient for ICU. So that patient need to be transferred. That's their recommendation. So okay, we want to transfer this patient, so we have to control. So we have to identify team leaders. So who will be going with this patient? So for example, this patient, because he's intubated, he will need an anesthesia registrar with him. He will need a nurse with him. He might need a pediatric doctor with him. So you have to identify the key task, the communication, who are the personnel, the equipment supply, and does the receiving hospital, do they have any specific transport advice they want us to give, for example, mannitol or anything else, or we can just transfer the patient and they will treat the patient. You have to control equipment and personnel. So for example, for this patient, he will be intubated, we'll need a mechanical ventilator, this patient will be sedated, so we'll need some infusion pump, so he will have IV access, we'll need to take fluids, we need to carry emergency drug, we have to be familiar with this equipment. Uh, we and we have to make sure that all this equipment are fixed within our transfer vehicle. The personnel, you have to send with the patient an appropriate trained patient. So you have patient who is intubated, who is mechanically ventilated. So you need an anesthesia registrar who can handle this patient properly. And they should be able to operate within the transport environment. And they should be obviously appropriately closed and equipped. Then you communicate. You communicate with the referring staff. You communicate with the ambulance service. There's a transfer team member who's receiving hospital with the family. That's really very vital. Sometimes in certain area, the people transfer the patient without ensuring that the receiving hospital are expecting that patient. That might affect the patient care, it might lead to delay in care, and sometimes the receiving hospital might not even accept your patient. And then you find yourself having a sick patient, you don't know where you can send that patient to. So you have to ensure that somebody there is accepting the patient, they are waiting for him. Okay, we are moving now, we'll be reaching you, for example, in 2 hours, and even before you approach them, you'll call them, we'll be there in half an hour. Now we are there, this is the patient. So you communicate your role, the details, the patient situation, the patient background, your assessment, your recommendation, and to see if they have any questions about the patient. Do they want any specific investigations or whatever? You have to communicate all that with them. And you have to do a proper documentation. So the referral should be documented. If they give any advice, that should be documented. Any follow-up calls, that should be documented. Any advice, all that should be documented properly. Then you evaluate. Okay, now we stabilize our patient. Do we need to transfer this patient? Yes. For example, let's assume that we want to transfer this patient. So now we know that this patient needs to be transferred. The accepting institute are waiting for us. My colleague who will go with me are okay with that. And then we have to ask ourselves, how urgent do we need to transfer? Does that need to be immediate? So we have to load and go, or this is just, for example, an elective referral can be done, for example, whenever the staff is available at some point. We have to decide about that. So we have to prepare back and everything. Make sure that the patient has been resuscitated and stabilized. We cannot transfer unstable patient. We have to stabilize the patient. And keep in your mind that you don't want to do many interventions on the way. So if you think that this patient airway at risk, then you have to intubate the patient before you go. If you need any lines, do them. IV line, arterial line, central line, do them before you go. Ensure that the airway is well secured and you have a good vascular access and you have a good monitoring. Secure all access, chest drains, NG tube, secure the patient trolley. The ambulance have a specific system that the patient trolley will get fixed with the ambulance. You gather your documents. Check the patient status. Check the equipment, documentation, personnel, and all the way down to the hospital. Do frequent checking for vital signs, for blood glucose. If you have a head injury, you have to look frequently for the pupils for any change in the pupil findings. You have to calculate your oxygen requirement, so it will depend on the total journey time and the ventilator or how much oxygen that this patient is receiving. And to make your life very easy, you can scan this QR code. It will take you to online oxygen calculator. So you can put all these parameters. For example, patient on a non-repeating face mask on a 10 liter of oxygen, and you are transferring this patient, and the trip will be for 1.5 hours. So you put all these variable. It will tell you how much oxygen that this patient will need, and also it will tell you what kind of oxygen cylinder you should take with you. Should you take the bigger size DD or a smaller size. It is dependent on the patient need. Make sure that you have enough oxygen. The worst case scenario is that you are in the middle of nowhere and you run out of oxygen. That's a disaster. You don't want that to happen to you. Then you transport. You leave your hospital. You're going to the different hospital. You have to keep communicating with that hospital. Now we left our hospital. We will be there with you within 2 hours. You call them again. Now we'll be there with you within 1 hour. And you keep informing them about the patient situation. And if there's any major change, you have to let them know. Sometimes you might be having a very high risk transfer, so you have to keep continuous communication with the receiving facility. So unfortunately, sometimes many unwanted events happen during transfer. So you have to prepare to prevent them and you have to manage them properly. So stabilize the patient, assess ABCD approach, make sure that you have your equipment, plan your care. So obviously, for example, if you are transferring a head injury patient, you should be thinking in your head what would be the unwanted scenarios that could happen in the way and how could I recognize them and manage them and communicate with the receiving hospital. So the accept approach, if you did it properly, it will help minimizing the risk. Preparation of the patient, equipment, and team will save you from all of the troubles. And you have to think of contingency. Make sure that the ambulance has a good fuel. Make sure that you have access to power, oxygen, excess oxygen in case you need. So commonly during transfer, airway problem happen. So the ETT tube can get displaced with the road. And the only way to recognize that by having continuous capnography. So now it's becoming a gold standard. Any intubated patient who is transferred, you will need to have a capnography monitoring. ATT tube cuff leak or tracheal tube obstruction. Again, the capnography will tell you, the examination will tell you, the ventilator will tell you. You have to think of that. Breathing. Sometimes the ventilator might fail. If that happens, then you might need to use the back valve mask until you reach the hospital. Sometimes dopes happen. So tube displacement, obstruction, pneumothorax, equipment failure. So you have to examine the patient thoroughly from the ventilator up to the patient lung and vice versa, so you can identify the cause. Circulation. So you lose your monitoring waveform. You lose your invasive monitor power. Syringe pump might get faulty or run out of power, and the patient might have cardiovascular collapse because of arrhythmia or cardiac arrest. So you have to have your drugs ready in case that happens. Disability. So patient, sometimes with the transfer we give the patient initial sedation, but we forget that this patient might need continuous sedation until he reaches the receiving facility. So that might happen. The patient might be agitated during transfer, and you have to always check the dextrose because the patient might be hypoglycemic. Check the environment. Some people might not tolerate the ambulance movement as they might get motion sickness. So if you are one of these people, make sure that you have your tablets before you go to the ambulance. The vehicle might become lost, accidents could happen, even breakdown could happen. So you should always think of plan B. If that happens, what should I do? Human factors are really important in transfer. So we need to have clear systems, processes, and procedures for transfer. So each hospital should have clear plan. So if we, for example, we have a patient who is having a head injury, need to be transferred to a different hospital, which hospital will be the receiving hospital? How can we contact them? How do we prepare our equipment? How do we prepare our staff? And we need a training to ensure that all our transfers are effective and safe. And communication is really important. So SPAR tool is very important. Close loop. Keep an eye contact with your colleague. Ask, make sure that they understood all your content. Avoid jargon and communicate through your team leader to ensure that all the message has been relayed properly. Thank you so much for your attention. I hope uh, I made those concepts clear, and I wish you all the best for your course and have a good day.